Thank you. Hope you had a good lunch. So now it's wake up time and you need to vote now, right? So I'll just explain what will happen. So we have four debates, and each debate, pre-debate and post-debate, you have to vote what you think about the two debate, and then the presenters will present and the panelists will talk, and after that also we will have a vote. So what you need to do, you just scan the QR code. I think you must have done it, and you have to register and get into the system. And we will put the first debate topics now. Have you all done this? How many registered? 42. So there will be a QR code going behind also. So if you can't scan it, you can scan it now and register. Okay. So can you display the first debate? Yeah, the first debate is laser versus anti-VEGF in proliferative diabetic retinopathy. So voting starts now. Put the questions. So just vote. If you think that laser is better option than proliferative diabetic retinopathy, or VEGF is better than laser, vote on your phones. And meanwhile, I would like to invite the two panelists to the stage. Dr. P.C. Haranathan, he is a vitreoretinal surgeon at Kandy Hospital, and Dr. Mangala Dhanapala will be joining us with Zoom. And I would like to first invite Dr. Chamira, who thinks laser is a better option for proliferative diabetic retinopathy, to talk on it. And then Dr. Nevinda will be talking on VEGF is a better option for proliferative diabetic retinopathy. Both are senior registrars in vitreoretinal surgery. So over to you, Chamira.
Dear speaker, it's going to be a debate. So the rule number one, if the speakers you have equipped with firearms, please surrender it here. No shooting. So it's a debate, so no shooting. So if you have any firearms, explosives, please surrender it here. Rule number two, no exchange of violent language. No physical contact. So these are the rules. So I would prefer to follow the rules. Okay, it's your time.
Thank you, sir. So to start on my topic, laser in proliferative diabetic retinopathy. So as you know, proliferative diabetic retinopathy is a leading cause of global blindness, and laser for 4 decades or so has remained the gold standard of treatment until the advent of intravitreal agents recently in the 20th decade. So still, it remains a mainstay of treatment, providing an effective long-term therapeutic effect in proliferative diabetic retinopathy. And it prevents progressive neovascularization by destroying the ischemic retina and increasing the oxygen tension in the eye by reducing O2 consumption in the photoreceptor layer and increasing the O2 diffusion from the choroid in the areas of laser scars. And major landmark studies advocate the use of PRP in PDR to reduce disease progression and as well to prevent severe vision loss. So moving on to the supporting trials and major landmark studies. The DRS is the major landmark trial which we base our treatment protocols on, and it has evaluated the safety and efficacy of PRP in reducing visual acuity loss in advanced proliferative diabetic retinopathy. And moving on to the trial, the candidates were those who had the presence of PDR in at least one eye or severe NPDR in both eyes with a visual acuity of more than 20/100. And in this trial, one eye was randomly assigned for PRP with the other serving as a control. And these patients were followed up at 4-monthly intervals. And in the primary outcome of the DRS trial, scatter PRP, both argon and xenon, was found to have reduced severe visual acuity loss by more than 50% through the 5-year follow-up period. And the eyes with high-risk PDR seem to achieve the best benefit out of PRP in PDR. And the secondary outcomes also show that there was a reduced rate of progression to more severe stages of PDR and a reduced risk of elevation of IOP by possible reduction of neovascular glaucoma. And certain risk factors such as the presence of fissures or preretinal hemorrhages, the presence of new vessels, and the location of new vessels were identified as significant risk factors of severe vision loss and were deemed treatment for PRP. So in conclusion, the DRS trial provides a firm evidence-based support for effectiveness of PRP in reducing the progression as well as preventing severe sight loss in high-risk PDR eyes. The second trial I'll focus on is the ETDRS. It assessed the efficacy of argon laser. It assessed the efficacy of argon laser and also in preventing progression of PDR as well as the best timing to initiate PRP in these eyes. And again, one eye is assigned for immediate laser while the other was followed up 4 monthly, receiving scatter laser if it progressed to high-risk pre-proliferative stages. And again, results of ETDRS showed that there was statistical significant reduction in severe visual acuity loss, particularly those with type 2 diabetes. And it was crucial in determining the role of scatter PRP in reducing the risk of DR progression and the visual acuity loss in these eyes, and also identify the ideal timing of PRP being severe NPDR or early PDR state. And now the protocol S is a significant trial which more or less swayed the tide towards the favor of intravitreal agents. And as you know, in the 2-year outcome of protocol S showed that while ranibizumab was non-inferior to laser treatment, it also was associated with reduced in peripheral field loss and fewer cases of diabetic macular edema on onset. And the 5-year outcome, however, showed that both approaches were equivocal, with both PRP and intravitreal ranibizumab showing mean similar changes in visual acuity score and approximately same mean visual acuity following 5-year treatment. However, it is also important to note that there was a high rate of loss to follow-up, despite the DRCRNet's high considerable resources available to reach these patients. 74 patients in the ranibizumab group and 80% patients were lost to follow-up during this trial. So while protocol S gives confidence in anti-VEGF as initial treatment of PDR, the important factor we have to notice that the patient-related factors, especially patient compliance, need to be taken into consideration when we're deciding on a treatment therapy. And the CLARITY study is another trial that evaluated intravitreal aflibercept compared to PRP in PDR eyes. And again, the primary outcome showed that aflibercept was non-inferior to PRP. However, on another aspect, the treatment with aflibercept was associated with a greater financial cost, with additional cost per patient being British pounds more than 5,000. So at an additional cost, the CLARITY study showed that aflibercept might be effective as an alternative treatment option. So again, it's important to take into consideration real-life scenarios, such as the patient's financial, social factors, which may limit his follow-up and return to repeated injections, which is required in anti-VEGF therapy. So compared to intravitreal agents, later treatment has the benefit of reducing the number of required injections, while also providing a highly effective and long-lasting therapeutic benefit. So in conclusion, while anti-VEGF intervention is highly effective in regressing neovascularization in PDR eyes, it is frequently not a durable therapy. So it needs long-term follow-up and repeated injections. So PRP offers a more definitive, durable, and cost-effective treatment to prevent the severe vision-threatening complications such as neovascular glaucoma and tractional RD in PDR eyes. So therefore, it's supporting in evidence of PRP in the case of PDR eyes. Thank you.
Yeah, thank you, Shamira. And now it's Nevinder's chance to defend himself.
Right. So, good afternoon, everyone. So, I will be presenting my facts for the anti-VEGF use in PDR. So, in the end, I think you will be able to change your minds and make a better choice. So, first I will discuss why not PRP. So, and as you all know, it's an age-old method, and it ablates peripheral retina and causes permanent and irreversible peripheral vision loss. As Tamira said, its main evidence comes from a trial which was done about 50 years ago. It's called diabetic retinopathy study. And this was done even before I was born. I was born in 89. So Tamira is same as my age. So he's talking about a trial which was done 10 years before we were born even. So there are newer methods available. I will tell you those in the next few slides. So first, let's discuss about some limitations in PRP. It needs a cooperative patient and a clear view of retina. And there is permanent loss of peripheral vision. And patients may complain of nyctalopia. And there would be worsening of macular edema. And there are occasions that CNVs occur, and there is mydriasis and loss of accommodation with heavy PRP, and there is a possibility of uveal effusions as well. So why anti-VEGFs? It's a quite modern modality of treatment which was introduced into the ophthalmology field in early 2000s. And there are about 5 agents which are being currently used. And except bevacizumab, all other 4 agents are having FDA approval to be used in diabetic macular edema. And out of those 4, ranibizumab and aflibercept have the approval to be used in diabetic retinopathy as well. So what are the evidence for anti-VEGF as a first-line treatment in PDR? So there's a ton of evidence, but the main 2 evidence trials would be DRCR protocol S and the Clarity. So as Puncheva rightly explained, ranibizumab was found to be non-inferior to PRP by the DRCR protocol S, and it further goes on to say that when compared with PRP, it gives better visual outcomes in terms of best corrected visual acuity and fields. And there is less development of diabetic macular edema and less chance of vitreous hemorrhages and less need for vitrectomy. And the same was confirmed for aflibercept as well. Actually, it was found to be superior to PRP by Clarity trial. So what are the benefits of anti-VEGFs? It preserves peripheral vision, and it concurrently treats diabetic macular edema, and it gives better best corrected visual acuity and better improvement of ETDRS severity score and less chance of vitreous hemorrhages. All these are confirmed by famous studies, and they are statistically significant. So how, of course, he mentioned about side effects. Of course, there are side effects in any treatment modality. So how do we avoid those outcomes? So he did mention about infection, and we can avoid those infections, the risk of endophthalmitis, by strictly adhering to sterility protocols. And there is always the issue of compliance and cost. So the better patient election, patient education is a possibility. And there is always nowadays available biosimilars. So it's a new trend, and they are much cheaper. So what about the anti-VEGF crunch? We can avoid this by doing a better patient selection as well as doing timely interventions as well. And regarding systemic side effects such as thromboembolism, there is contrasting evidence, and there is no definitive evidence to support that. So what are the other indications for anti-VEGFs in PDR? As I said, it treats concurrent macular edema, and these trials support that. And for vitreous hemorrhages, when you can see the fundus, you won't be able to do any PRP. So anti-VEGF is option. And for persistent new vessels, even after completing PRPs, and for NVIs and NVGs, anti-VEGFs play a role. Anti-VEGFs also is beneficial in pre-op adjunct for TPPV. So these are the benefits. If you give anti-VEGF before TPV, it reduces intraocular bleeding, surgical time, and reduces iatrogenic retinal breaks, and eases delamination of fibroblascular membranes. Post-operatively, it reduces post-op vitreous hemorrhages and NVG occurrence as well. All these benefits are statistically significant when compared with PRP, and it is confirmed by multiple trials. Thank you. I hope now you can make a better choice. Thanks.
Thank you very much, Navinder. So, a lot of confusing research and stuff. What do you do in your practice, Dr. Sri?
Both speakers done very well and they obey the rules. No one shot each other. And one thing is mainly there is no one go for all times. That means you have to select your patient which is better for your patient. This either Avastin or anti-VEGF monotherapy or PRP monotherapy, which is suitable for your patient. You have to choose it. That's why we are humans. We are not artificial intelligence. So here you have to use your intelligence. Which one going to suit you, your patient fit for? I am old man, as Naminda said. All people like to have all things because we trust them. We have long-term trust. Maybe most people trust all things. So I prefer PRP as a first line because our patients are unreliable. They come only 2 visits and they disappear from your radar. Then you can't find them. So in that case, I prefer to have a PRP when there's a reliable patient who is motivated. So I would prefer to go for anti-VEGF. So it depends on your patient you choose. So both has evidence, both has its flip side and the bright side. So it depends on that. You explain to the patient and you decide on your own.
Thank you, Dr. Sri. So there is a lot of psychosocial things that you have to consider on treating individual patients. So Mangala sir, what's your opinion? What do you do in your practice, in your experience?
Yeah, it's, can you hear?
Yeah, we can hear. We can hear.
Okay, yeah. Actually, the debate should be, which should be given at what stage, okay? Because, both modalities are really useful. If you really look at the way, anti-VEGF is just giving paracetamol to fever, you have in PDR, you have a high VEGF drive, you try to suppress it, but it doesn't do anything to your disease. Whereas PRP has some effect, right? The most of the complications of PRP happens not because PRP is a failure, but we don't do it properly, okay? And then, Navinda talked about the peripheral vision loss. That's something the real protocol S was trying to put forward, but actually they failed in 5 years. Peripheral vision loss is not only due to laser. In diabetic patients, one of the key mechanisms is microinfarcts or retinal ischemia, right? So that also can lead to peripheral retinal ischemia. So that is one of the things. Macular edema is another issue. They say, you have a patient who has macular edema plus PDR, then maybe anti-VEGF has a better effect. But mind you that you should always add some layers. Otherwise, if you lose the patient for follow-up, patient will come later with a very bad disease. So my opinion, why they develop C and V is because you have used too much of power. It is not because of the failure of the procedure. It is because we have not done it properly. And if you have ended up in a huge peripheral vision loss, again, it is because you have not done it properly. You have probably used too much of power, or maybe your spacing is not correct, something. So I think both are really necessary, and rational use of both will probably save our patients.
Thank you very much, sir. So it's about sort of a individualized management, and laser also you have to do it properly and select the patients wisely and treat them. So anything to add, Dr. Sri? So we'll move to the next. And before that, previously most of the audience thought that laser is the treatment for diabetic retinopathy. We will have another poll. So can you put on? So you need to scan it again and vote. 30 seconds. So meanwhile, I would like to invite the next panelist, Dr. Prasad Patirna, consultant eye surgeon at Eye Hospital, and Dr. Gayan Vijayasundara, he's a consultant eye surgeon at Polonnaruwa. Please come to the stage. And next topic will be SLT versus medication in glaucoma. So can you put on the questions?